Yeah, good evening, everybody. From Daily Liver Foundation, it is my proud privilege to welcome you all for our very innovative webinar series on the prominent topic of obesity. This is our third endeavor. Initially, we did talk on pathogenesis of obesity, the various aspects and assessment and measurement of the obesity. And today we are going to talk of something which is relevant not only to the gastroenterologist, hepatologist, but I think every clinician and everybody in general population also. Today we are going to talk about the role of diet and exercise, not only its role, but we are going to discuss the science and the clinical applications of diet and exercise in management of obesity, which has its own onerous implication and complication. So Ashish, would you start the proceedings now?
Yeah. Good evening, ladies and gentlemen. I bring you greetings from Sir Gangaram Hospital. And on behalf of Delhi Liver Foundation, I welcome you to this webinar. As Dr. Arora already mentioned, that as we are going through a challenging time facing this pandemic of coronavirus disease, and we hope this pandemic to get over within a few months with the vaccine, but we still continue to face an even greater pandemic from which most of us are affected. That is the pandemic of obesity. And with it has its own set of problems and complications like diabetes, hypertension, increased risk of cardiovascular disease, and of course fatty liver and NASH related cirrhosis. And there's no vaccine in sight for pandemic of obesity, and only chance is prevention of obesity and better treatment of obesity by understanding its pathogenesis and its management. In this direction, Delhi Liver Foundation had planned a series of webinars to better understand the pathogenesis of obesity, its prevention and treatment. And today we have the third webinar in that series where we'll be discussing the diet and exercise, and which will help us in prevention and treatment of obesity. But prior to this academic feast of lectures on and discussion on obesity, the Delhi Liver Foundation would like to felicitate one of the greatest gastroenterologists in India. As you all know, that from last 3 years, Delhi Liver Foundation, in the memory of Dr. S.K. Sama, has been recognizing and felicitating senior gastroenterologists who have made significant contributions in GI and liver field in India and have dedicated their life in improving the GI and liver health of Indians. Today, we would like to honor Professor Jung Dilavri, who has been the teacher of our teachers of hepatology and gastroenterology, and has been he has taught us, all of us, and he has made significant contributions in hepatology. So I would request first Dr. Naresh Bansal to give a brief introduction about Dr. S.K. Sama and his life in gastroenterology. Then I would request Dr. Tyagi to give a brief introduction about Dr. Dilavri and read a citation about him. To Dr. Naresh Bansal.
Thank you, Dr. Ashish. I'm just sharing my screen. Is it visible to all?
Yes.
Yeah. So at the outset, I would say that it's a matter of great honor to me to pay tribute to a personality like Dr. S.K. Sama, who had been my mentor also, and who was a great statesman as well as a great scholar and gastroenterologist. He was respected and appreciated among all the faculties, gastroenterologists, and by his juniors as well as seniors. In his memory, I know that he needs no introduction among the faculty gastroenterologists, but just few slides about him. That he was born on 31st May 1934 at Firozpur. His primary schooling was in Bilaspur, Himachal Pradesh, and then he did his MBBS from Medical College, Amritsar. After that, he entered in All India Institute of Medical Sciences to complete his MD Medicine. And you can see his forevision that at a time when nobody was interested in gastroenterology and there were hardly any investigations apart from few variant studies, he went to Tufts University, Boston in 1970 itself for training in gastroenterology. His brilliant career was started by joining his alma mater AIMS. He stayed at AIMS till 1974, during which time he established the Department of Gastroenterology at the institute as well as at G.B. Pant Hospital. In 1976, he joined Sir Gangaram Hospital as an honorary physician of gastroenterology and served the hospital for 36 years, including as its chairman from 1995 to 2006. While continuing his association with Sir Gangaram Hospital, he founded the multi-specialty hospital, which is known as Sama Hospital in 1982 in South Delhi. He was personal physician to the President of India and he was appointed to this honorary post in 2001. If you talk about Sir Gangaram Hospital career, then he founded the gastroenterology department in Sir Gangaram Hospital, which has now grown to become a center of excellence. He held various posts at the Sir Gangaram Hospital, including that of the founder member of the Board of Management and was also a member of its Board of Trustees. He remained chairman of Board of Management from 1995 to 2006 for 11 years consecutively. He was a teacher par excellence. He was an excellent teacher and his devotion to academic remained with him till his last breath. He was a role model for many medical students and budding gastroenterologists. He was a keen researcher as well. He was a pioneer of medical research on liver disease in India. He published 51 high-impact articles in various national and international journals. His 1962 article is reported to be first attempt at describing the non-cirrhotic portal fibrosis, NCPF. He is also credited with significant research on hepatitis B. He had always been inquisitive and had the zeal to learn the latest technique in gastroenterology. He contributed to medical societies immensely. He was the former president and a life member of the Indian Society of Gastroenterology and organized 6 therapeutic endoscopic workshops. He was life member of the Indian Society of Study of Liver Disease, Indian Society of GI Endoscopy, American Gastroenterology Association, and Association of Physicians of India. He was president of the New Delhi chapter of IMA. He was board of advisors of the member of the, he was advisor to the American Hospital Management Company. If we talk about awards, it's a huge list, including one of the biggest award, Padma Shri in 2004, which was given for his statesmanship and his pioneering research on liver disease, including non-cirrhotic portal fibrosis and hepatitis B. He received the highest Indian medical honor of Dr. B.C. Rai Award in 2004. He was also a recipient of several other awards, such as Punjab Ratna Award, DMA Ratna Award, Bharat Jyoti Award, Bhaskar Award, Human Care Award, and Delhi Ratan Award. He has delivered several award lectures or orations, such as Presidential Oration, Dr. B.L. Kapoor Memorial Oration, Dr. K.L. Vig Memorial Oration, and Dr. R.S. Tiwari Oration. In the last, I would say with conviction that he was father of gastroenterology in India. He was teacher of teachers, not only astute physician, he was an able administrator as well. 2 qualities very difficult to find in a single person. I think to acquire these two traits, one has to take 2 baths. My heartfelt tribute to my mentor, my teacher, to this statesman, to great scholar, and to a great gastroenterologist, Dr. S.K. Sama. Thank you.
Thank you, Dr. Naresh. Now I would request Dr. Tyagi to read the citation about Dr. Dilavari. Dr. Tyagi, you are muted. Please unmute yourself, Dr. Tyagi. Yeah.
Respected delegates, it's my honor to introduce to all of you Professor Jang Bahadur Dilavari, the recipient of 2020's Dr. Sama Memorial Award. Professor Dilavari's early years were spent in training with the likes of Sir Francis Avery Jones, considered by many as the founding father of British gastroenterology, with Professor J.J. Misivich, who not only became the president of British Society of Gastroenterology, but also the editor of Gut. Margaret Shiner, the inventor of Shiner capsule, and Peter B. Cotton, considered by most as the father of ERCP. He worked also with Christopher Williams at a time when colonoscopy was in its early days. His training in hepatology was with Laurie Blendis, Dame Sheila Sherlock, and Roger Williams. All three of them require no introduction. With such distinguished tutelage, Professor Dilavari could well have achieved fame under any of these greats in UK. But when invited in 1977 by Professor P.N. Chutani to join the faculty at PGI Chandigarh, he immediately, without a second thought, accepted the offer. In many of my personal conversations, I have asked him why, to which he has replied, "It was an opportunity to be back in my country and be useful. It offered great opportunities to teach endoscopic procedures, especially pancreatobiliary procedures, to fellow gastroenterologists." For the next 20 years, Professor Dilavari passed on his skills not just to young gastroenterologists at PGI, but across the country. Pancreatobiliary endoscopy was in its nascent stage in India then, and his mission was to make it as good and perhaps one of the as best as existed in the world. No wonder he is known as the father of pancreatobiliary endoscopy in India. I had the personal opportunity to be standing by his side when he first removed the CBD stone at PGI. As a junior resident, I was far removed from being his assistant, but I was fascinated by the way he did it and what happened. And that, like many others, brought me into the field of gastroenterology. Professor Dilavari was a 24/7 teacher who never berated his students while teaching them skills as only he could. Mind you, those were not the days of video endoscopy, but we had to do with a lecture scope, which practically let you see very little. Today, several of those whom he tutored are recognized as one of the best, be it in the field of clinical gastroenterology, therapeutic endoscopy, or hepatology. I'm not going to name them because today is Professor Dilavari's day. A lesser known fact is that he and his wife, Rani Dilavari, have founded a trust called Nurturing Young Lives that will work with children of socially and economically disadvantaged group. Through healthcare and education, he wants to help them, his trust wants to help them grow as responsible citizens. With such a legacy, he transcends the boundaries of being famous and steps into the realm of being a legend who leaves behind his students, his benefactors of the trust, to pass on the dreams, his dreams, generation to generation. having shared the same space as him has been an honor, a privilege, and a pleasure for all his students and his colleagues. This award, sir, may be rather small for a legend like you, but the gastroenterology community, it's a means of expressing their gratitude to a living legend. Thank you.
And now I would request Dr. Dilavari to say a few words about his journey of gastroenterologist in India.
Well, let me first of all say thank you, Dr. Tyagi, for saying these wonderful words. Hearing from you, it's amazing. And also Dr. ANIL ARORA for choosing me to get this award. Dr. Sama, I knew him when I was in PGI Chandigarh. I didn't know that Dr. Sama had contributed so much. I knew he made the best gastroenterology, the private gastroenterology department, and surgical gastroenterology as well. And he was the one who actually got big surgeons like Nandi to Gangaram Hospital start the transplant program. So Dr. Sama's contribution to the Indian field of gastroenterology has been really tremendous, building such a world-class department of gastroenterology. Now, I'm indeed honored, and it gives me tremendous pleasure, and I'm privileged to have this honor. Actually, this honor, although given to me, but behind that are my teachers in Germany, in UK, and particularly my postgraduate students, and Tyagi is one of them, my postgraduate students in Chandigarh, in PGI, and they have contributed a lot to this award which I'm receiving today. So I'm receiving this award on behalf of my teachers abroad and on behalf of my students in PGI Chandigarh. Thank you very much indeed.
Thank you, Dr. Dilavari. So this being a virtual conference, we cannot hand over the award, but we give you a standing ovation for this. And now we move on to the proceedings of the webinar. And I would like to invite Dr. Sudeep Khanna, Dr. V. Jayanti, and Dr. Ramesh Rupray to now carry on the proceedings from here and moderate the session. Thank you.
Good evening, sir. To all the participants of this important webinar, on behalf of everyone present here, we bring and say salute to our teacher, Dr. Jangbi Dilavari, who has contributed through his students so much to Indian gastroenterology. Thank you very much, sir. We all have been your beneficiaries. Today's seminar, which as Dr. Ashish mentioned that it is a pandemic and obesity is a pandemic. Everybody is fearful. Everybody wants to shed his weight, but so difficult to do it. So in the periods when this thing is coming as a pandemic, 1/3 of our population is getting affected. Now it is time to think as to how to achieve that goal so that everybody can be as lean and thin as he imagines for himself. And to do this whole process, we are having this seminar. Today, our first speaker is Dr. Setu Babu. He is the senior gastroenterologist and a famous academician who has contributed a lot to the Indian gastroenterology. He passed out his DM from All India Institute of Medical Sciences and is a prolific reader and a prolific researcher. I invite Dr. Setu Babu to talk about as to what type of diet should be taken, what is the timing that it should be eaten so that you can achieve the goal of reducing your weight. Dr. Setu Babu.
Thank you to everybody, and it's my privilege to have Professor Jang Dilavari, whom I saw doing ERCP when he was invited to All India Institute as trainer, and he used to come and teach us. I don't know why I agreed, because I'm always afraid of Anil Arora. The moment he says talk on a topic, I accept it, with the humility and then do it. And today's topic, uh, on the overall topic of diet and exercise, timing and pattern of diet. I thought that's such a simple thing. Why bother about it? But then when I went through, I was amazed. Let me share. Quite a confusing topic, but let me share in the short time something new that has arisen there. Food is a very exciting thing. You see that there's something called Bahubali Thali in Chennai, which costs 1999 rupees. And you know that everybody enjoys food. It could be for 24 hours. And the lockdown has actually made a different, uh, people couldn't stop their binge eating. So why do some eat more? This is $1 million question. And probably we go back, maybe I should talk genes at the end, but let me talk genes the first. It changes the appetite behavioral trait and adds the environment adds to it. So you have an appetite and you have an environment, naturally your food take increases and you tend to gain weight. We will go into the details of the genes later. The timing of food intake, does it affect everybody or it's actually genetics? Suddenly we found a candidate gene on obesity that promotes fat storage in the adipose tissue, and it also limits the lipolytic activity using the hormone sensitive lipase. Obviously there is a link on appetite, obesity, and or the fat storage. In fact, if you look at obesity treatment, it shows a large variability on body weight loss in response to any of the weight reducing programs. But these seems to be related to the behavioral factors like unfavorable eating behavioral traits, increase in hunger, increase in fasting hunger, and they have been associated with reduced ability to lose weight. This indicates that there is a physiological or behavioral factors that could be implicated in your ability to lose body weight. Despite some of these variations like energy intake or eating behaviors or appetite sensitivity or sensations, they influence the response in the body weight loss. There is something called body weight loss resistance, and if it can be assessed before your intervening procedures, you can actually have a designer diets for obesity intervention, which I'm sure Ashish would look into it. What is the current state of our knowledge? Are the calories the whole story? And here comes the macronutrients, because that's what we talk about: protein, fats, and carbohydrates. Is it possible that the answer is hidden in some of the traditional diets? You call the Mediterranean diet, the continental diet, and then is time related dietary approaches, time to eat and meal timing, that is my topic which I need to address. So we look at the time to eat, timing of meals, and is there a difference of macronutrients like taking more fatty breakfast and less carbohydrate in dinner? Do we mean that? One word is energy density, a modified term for calories. I won't talk much about it. But then what happens? There is a close linkage between the energy density of the foods we use and the foods we consume as per the timings. Though water is 0 and fat is 9, the energy density of food or the beverages determine the portion size. Like if you compare a watermelon piece and a pizza piece, the water content of the the fruit makes a lot of difference. So what is the timing of food intake and obesity? There are several animal models, and they were giving unusual feeding time. They develop obesity even without change in activity. These mouse are kept on roller coasters, and after the exercise, they were given food. in spite of the exercise, the weight gain. So high fatty meal at the end of active phase leads to increased weight gain. And the pathophysiological basis of these findings relies on a new definition of obesity, that it is a chronobiological disease. That means it also depends on the chronobiology of human living, and unusual feeding time can represent some kind of a circadian disruption. I think we are going to use this word circadian disruption because there is a clock, a circadian clock. You know the exogenous clock, but there is an endogenous clock which makes a circadian rhythm to answer certain foods. And the semantics, which are very complex, are uncoupling between the central and peripheral oscillators, circadian variations of peripheral clocks, gene expression, satiety hormones, and the digestive process. Ashish, there is a noise behind, I think. Okay. So we are using certain semantics which are applicable in the chronobiological aspects of human eating behavior. Among the mechanisms promoting obesity, there is something called diet-induced thermogenesis, which is lower in the night, and the reduced thermic effect of glucose in obesity is likely to be related to the nocturnal insulin resistance. I think there are diurnal studies on insulin response, and it varies between day and night. Additionally, reduced fat oxidation has been observed during nighttime eating, and that makes probably obese. That means if you eat more fats in the night, tend to become obese. When to eat? I think this is one of the questions which was posed by Anil and Ashish group, the importance of eating patterns in health and disease. While the quantity and quality of food we consume can affect our health, it is becoming more clearer what we eat when also makes a key role in health and disease. And meal timing could, in fact, there are studies which have shown that effective dietary strategies to combat obesity and type 2 diabetes and cardiovascular disease has something to do with the timing of food. We have another word called the chromonutrition, which has two aspects. Nutrients or food components regulate the clock system. For example, look at caffeine, which prolongs the period of circadian clock and the locomotor activity. That's probably where the more the caffeine you take, the more drive you get, and you tend to also eat little more. High fat diets alter the rhythm of lipogenesis, circulating lipids, locomotor activity, or feeding behavior. The point of contest is when somebody eats more, he takes rest, does it mean something? Or somebody eats more and he exercises, does it mean something? And the meal timing affects output of the clock system. Like skipping the breakfast and nocturnal eating, in fact, increases the risk of obesity. Whereas time restricted feedings called TRF prevents metabolic disorders. So regular time restricted feeding synchronizes and amplifies rhythms of our endogenous clock system, while irregular, unusual feedings cause desynchronization and attenuates the rhythms, and that leads to metabolic disorders. What we are trying to convince is eating at the right time, eating right quantity, and trying to look at the body requirement and probably honoring the endogenous circadian rhythm, which develops spontaneously in different individuals in different ways, makes some difference. So is there a biological basis of optimal meal timing? Again, I was using the endogenous circadian clocks, which happens to be a biological timing system. That means if you adapt your body to eat at a fixed time every day, the body adjusts to that kind of feeding every day, and your biological clock signals to respond to that particular food, that particular calories. And this way, your intervention also can try to reduce the obesity. So respecting the biological clock is very important. What is already known about this area is low weight loss responders have a priori difficulty to be identified by their baseline profile of body weight, energy intake or energy expenditure. I think this is something which we know that some obese people, in spite of their lifestyle modification, they become resistant. But if you have some features, we never look at exactly, we only say calorie restriction, but we never tell them, listen, there is something called timing of food intake. And more specifically, late eating has recently been identified as a determinant of obesity. I think this is a fact which I have learned is that when we talk next time to an obese patient, could we actually time apart from what they eat? So it is probably timing, quantifying, and qualifying. Three components go together in the management. For example, we know that the body expects to use certain kinds of fuel at specific times of the day, and your body is best at digesting food and drinks at particular time, particularly when you are active. Uh, I'm not really sure when we are all going through these webinars, and many of the people are missing their wonderful dinners, both as a a speaker, participant, chairman, and all. Are we missing something? The night heavy dinners, and are we losing weight during COVID phase? I do not know which we have to look at it, and that's where a very interesting which I know something, but then I never concentrated on that. That the Ramadan fasting alters the body weight, blood lipids, and fasting glucose. In fact, we used to say during Ramadan, say in a place like Hyderabad, where I practice, we get less number of patients, and we used to think that probably because fasting they're not coming. But I understand. I was talking to a few people the last 1 week, and they all started saying, no, no, we feel healthy during that period. And there are 30 articles, surprisingly, which looked at a lot of biochemical parameters in healthy subjects, especially men, that their biochemical response is extremely favorable. So is the timing of food intake a potential indicator of low weight responders? This is a 3 weight loss studies, and the answer is the big yes before I go into more details of that. Does timing of food intake, is it a sounding alarm about metabolic impairments? If you know the food is a major synchronizer of circadian clocks, that means we adopt it to, like many of us who work, are probably have a big breakfast, a light lunch, and maybe a major dinner, which could be wrong. That's what I understand. Maybe if you could change your circadian clock to a better breakfast and a bigger lunch and a smaller dinner, which doesn't normally happen, probably we should revise after this particular talk. Your daily eating duration is the number of hours between first and last. And there is a midpoint that you strike at it. I'll show you a graph. And while you are looking at calorie restriction and intermittent fasting as some of the issues which will be discussed when we talk about diet, time restricted feeding and time restricted eating specifically emphasizes a consistent response to the obesity intervention. Again, I was using the circadian, and you expand your circadian period by which you consume. I'll reduce the complex side into a statement by saying, if you could have majority of your meal in the morning hours and have a reduced meal or food in the night, probably you tend to remain normal. But if you change the midpoint of intake to a later period, maybe you start gaining weight. So the timing of breakfast, lunch, dinner affects the obesity, and metabolic risk has been confirmed in prospective studies. Individual consuming 20% of more their total energy after 8 p.m. All these days, probably some of us were under the wrong impression that the best thing is to skip the lunch. Probably is not correct. Even though there are contradictory results, the growing body of evidence, particularly some of these studies, consider the circadian timing of the individual and suggest that late eating is associated with higher body weight. And this was a graphical representation. After 20 weeks treatment of early eaters and late eaters, you could see a significant difference. And those people who have late meal tend to get obesity. Snacking is one word which I don't have to describe much, but evidence on the influence of snacking on the body weight is mixed. And also probably, there's something like if you have a snack which is around 200 calories, maybe you will escape the impact of gaining weight. I think this is very difficult. So some tomorrow you need to list what are the things which you can have a snack which contain 200 calories, or divide them into two snacks of 100 calories, which sometimes we do in the hospital, asking for a cup of tea and couple of biscuits, maybe adding the 200 calories. There's daily intake patterns that can help to lower dietary energy density. I think we have been now looking at breakfast, which is the pattern of food consumption over a day. The meals or snacks could affect your weight management. And if individuals are habitual breakfast eaters, including higher amount of protein and fiber during breakfast, they may help increase satiety, decrease energy intake, and lower dietary energy density. And this may lead to, either to maintain the weight or maybe even a weight loss approach to these people. The calorie distribution within the eating interval, and there is scientific evidence of which, there is already a big saying: eat breakfast like a king, and lunch like a prince, and dinner like a pauper. In fact, we don't honor. So it may be beneficial to consume majority of the calories in the first half. Seems to be one wonderful lesson after this particular talk. Even though the association between evening eating and body weight is not confirmed, but it seems to be a very important observation, at least in really subgroup of those smoking men or physiologically inactive or inactive women. Aside from body composition and weight regulation, timing of food intake seems to have a negative impact also on, look at HOMA-IR and a diurnal variation. Eating a late, if you take the HOMA-IR in those people who have a bigger breakfast and a smaller dinner vis-a-vis smaller breakfast, there seems to be a significant change. And this kind of insulin resistance may be detrimental to both diabetes management and obesity. The regularity of eating is another, again, we respect to the circadian rhythm, which I was talking. A consistently daily eating time may be beneficial, and even it tends to prevent obesity, diabetes, and all the metabolic events. So I think this is similar to the jet lag that happens. So we look at nutritional targeting by food timing, time-related dietary approaches to combat obesity and metabolic syndrome. And studies have examined the implications of eating at the right or wrong time. There are a few papers which talk about the macronutrient distribution in a day, that if you have higher protein and fat in the morning and lesser carbohydrate at bedtime, that would be a great help. So what is the best eating pattern? A consistent daily eating duration fewer than 12 hours per day. That means if you could have the major one in the morning, say 8 to 8, that 12 hours, this one, eating most calories in the earlier part of the day, and avoiding food intake close to bedtime while sleeping. This is a very wrong thing we do. And probably I would add to TV with children, and the typical scenario of having a popcorn or a packet something and then go on eating. And if you are immersed in the movie or TV serial, you may not even know it. I think when we talk about food eating, the intermittent fasting on health, aging, and disease, I saw a very good paper which was published early this year. Maybe Ashish would take it up, or we could probably discuss that. So what is these several different types of intermittent fasting, which will have an impact, because fasting is also time related, and alternate day fasting, alternate day modified fasting, and periodic fasting. Therefore, shorter eating durations and longer regular fasts may improve the health. We were also looking at the a model which has actually compared a controlled diet, or the Western traditional diet, and the cafeteria diet. So this is the first time I was looking at. I didn't know this something called cafeteria diet, which actually is a high-fat diet, and the impact of such cafeteria diet is it induces obesity, very important. And so one must, qualify the diet, whether you are having in a controlled environment, or the so-called Western diet, or maybe our diet would be something like a Mediterranean diet. But this cafeteria diet is something where you tend to eat more fat-containing diet, and you develop, obesity.
Dr.
The
Setu,
irregularity in breakfast, yeah, I
just
think I'll take care of it now. I would ketogenic diet, it will be addressed too, and there is some impact on bariatric surgery and obesity and timing of diet. I'm not actually going to talk on the impact of bariatric surgery because there are good weightless responders and secondary bad responders and primary bad responders. But the results in these studies showed that apart from these lifestyle factors, the timing of food intake. Suffice to say that even after bariatric surgery, one need to maintain the timing of diet so that he don't regain the weight. Otherwise, he would become, poorer and get by obesity. Anything surgery, and there is a lot of impact on timing of the diet and even a cardiovascular health. And there are studies called cardioveg trial which talks about the vegetarian diet and timings of this. So in conclusion, we talk it what is called chrono disruption, where from a chrono nutrition, and we look at the clinical consequences of timing, early food intake, and probably distribute it everything in the morning hours and reduce your dinner may mean that you prevent obesities, which is the target of our entire program. And I still don't know whether I did justice, thanks to Anil Arora, whom I am always afraid of.
Thank you, Dr. Setu Babu, for that wonderful talk and
Hi.
highlighting the various aspects of the timing and pattern of the diet in our day-to-day practice. Since all the topics are interrelated, we'll take up the questions at the end of the session. So we now move on to the next topic, and that is to be delivered by Dr. Ashish Kumar, a senior consultant at the Institute of Liver Gastroenterology and Pancreatico-Biliary Surgery at Sir Gangaram Hospital. He's a versatile speaker. He has several publications and a great hepatologist. Over to you, Dr. Ashish, for your talk on content and calories of diet as we consume in our day-to-day.
Thank you, Dr. Jayanti. Are my slides visible?
Yeah, it's
Yeah.
visible.
So I'll be talking about contents and calories of diet. So I'll begin with a case. So this was a 47-year-old male. He was from Delhi, from Punjabi family. He was a businessman, automobile accessory shop owner with a sedentary lifestyle. So his job was 9 to 9 sitting job in the shop, and there was no time for exercise. So he mainly consumed vegetarian diet, and he was non-alcoholic. So he comes with complaint of fatigue for last 3 months and pain abdomen in the right upper quadrant for last 1 month. He was diagnosed as hypertensive 1 year ago, and on examination, clinical examination, there was hepatomegaly, and on anthropometric measurements, his height and weight actually resulted in a BMI of 30 kilogram per meter square, which is in the obesity range. His investigations, hemogram was mainly unremarkable, but his liver function test, AST and ALT were raised. Uric acid was high. B and C markers were negative. HbA1c was in the prediabetes range. Ultrasound showed grade 2 fatty liver. The fibroscan liver stiffness was 8.8, and control attenuation parameters CAP was 358. So we made a diagnosis of non-alcoholic steatohepatitis with liver fibrosis because of higher LSM value, hypertension, prediabetes, obesity, and hyperuricemia. So this is the prescription which we handed over. First thing was we asked him for a weight reduction, dietary counseling, exercise, and few drugs. But the most important part of the prescription is what is dietary counseling. So in the dietary counseling, I, and along with my dietitian, actually asked him what he consumes throughout the day. So he told us that he consumes in the morning tea, he takes tea with 2 spoonfuls of sugars, biscuits. In the breakfast, he consumes about 2 aloo parathas, curd, then lassi, sweet lassi. In the lunch, he consumes 2 chapatis, some rice, dal, and vegetables, about 2 types of vegetables. Evening snacks he consumes at his shop, which consists of 1 tea and 1 or 2 samosas, which are available locally. And dinner was same as the lunch, 2 chapatis and this. And bedtime he consumes milk with 2 spoons of sugar. So this is the diet which he used to consume, and this is the diet which most of North Indians do consume, and there is nothing wrong in it. And at least we don't see anything wrong in it. It is not full of any junk food or anything like that. So what is wrong in his diet? But when we actually analyze the diet, we find that actually he's consuming too much of calories, there's too much of carbohydrates, too little protein, too little fiber, and too much of fat. Let us analyze the diet in detail. So if we see the calorie count, his breakfast in the morning tea is 20 calorie, sugar 30 calorie, and biscuits 80 calories. So the morning tea consists of 130 calorie, breakfast 785 calorie because of aloo paratha and all that. Lunch about 664 calories, evening snacks 410, again dinner of 664 and 190. If we total up all this, his total calorie content is about 2843 calories. Can you imagine this? He is just a sedentary lifestyle. He's not doing any exercise. He's going to his shop, sitting there from 9 to 9, and he's a sedentary individual. So for a sedentary individual, a calorie count of 2,800 is definitely much higher. According to the dietary guidelines given by the American Dietary Association, for a sedentary individual of male 31 to 50, the total calorie should be around 2,200 calorie, or at the most 2,400 calorie. And per day he's consuming about 400 or 500 calories extra. And now let us look at the caloric breakup. So this is the calorie breakup. His carbohydrate content of the total calorie is 60%, fat content 27%, and protein content is 13%. What is the recommendation? The current recommendation, according to various societies, the carbs should be about 50%, fat should be 30%, protein should be 20%. So in the fat, he's actually consuming 88 grams of fat, which amount is much high, although the percentage is okay, that is 27%, and recommended is 30%. Protein amount is too low for him. He should have been consuming 20% of protein, but he's consuming only 13%, and his total amount is 96 grams. But what he's consuming too much in term is carbohydrate. His percentage is also high and amount is also high, which is 432 grams. So what happens when we consume different level of carbohydrate? If someone is consuming very less of carbohydrate, it leads to ketosis and fat burning. It may be helpful for certain people with insulin resistance. If someone is consuming 50 to 100 grams of carbohydrate per day, it may be good for a person who is not exercising, and it is easy to keep the weight off. If someone is consuming 100 to 150 grams, then the person, if it is a good level, if the person is active and healthy. And if someone is consuming 150 to 200, 300 grams, it is actually slightly on a higher side. And it also depends on the activity and insulin resistance. But a person who's consuming more than 300 grams of carbohydrate, this is far too much. And this is what it drives insulin resistance. So if someone is consuming 200 kilocalorie diet, his carbohydrate intake should be not more than 1,000 calorie. That means 50% from the carbohydrate. And that 1,000 calorie it actually amounts to about 250 grams of carbohydrate, and not much. So if you have to remember just one thing from my lecture is this thing. If you're consuming whatever amount of calorie intake, 2,000 calorie, 1,800 calorie, the carbohydrate content should not be more than 50%. So for a 2,000 calorie intake, it should not be more than 250 grams. Having said about the carbohydrate content, there are various types of carbohydrate, and not all carbohydrates are equal. So carbohydrates can be divided into 3 types. One are sugars, then starch, and fibers. Fibers are the non-digestible type of carbohydrate, which are constituted by vegetables and whole grains. Carbs, the starch is the digestible type of carbohydrate, although slowly digested, and cereals and potatoes are there. And sugars are rapidly absorbed carbohydrate like glucose, sucrose, and fructose. So multiple studies have already told that excess sugar consumption, uh, if it is not utilized immediately by the body, they are converted into fatty livers, and it leads to de novo lipogenesis. And it leads to lipotoxicity, that is steatohepatitis. It leads to increased accumulation of steatosis, triglycerides in the liver, and it is also exported from the liver in the form of VLDL and increases the cardiovascular diseases. So multiple studies have already shown that fructose and sugars are major driver for non-alcoholic fatty liver disease and various cardiovascular diseases. And a 3-month daily consumption of sugars and sweetened beverages actually drives the increased lipotoxicity in the liver. And sugar sweetened beverages drives the fatty liver disease. This has been shown in the Framingham Heart Study. And also, sugar sweetened beverages are as bad as actually alcoholic beverages. So they are actually similar. And this has been a meta-analysis that sugar sweetened beverage that consuming lots of sugars actually increases the risk of fatty liver disease, and it increases by 1.5 times. And it is high sugar but not high fat diet that leads to hepatic triglyceride content increase. So high sugar diet not only leads to weight gain, hyperlipidemia, hyperinsulinemia, it upregulates various proteins which are bad for the liver. It also leads to nitrosylation of protein and mitochondrial fission. But high fat diet though may lead to a weight gain and hyperlipidemia, but doesn't lead to all other problems which are due to high sugar diet. So it is high sugar diet which is more of a problem than a high fat diet. So, what is the daily added sugar limit? According to various guidelines, men should consume no more than 9 teaspoonful or 36 grams of sugar, and women should consume no more than 6 teaspoonful or 25 grams of sugar. But this is for a healthy individual. If the person already has diabetes or if he has metabolic syndrome, NAFLD, obesity, it is much better to avoid the sugar, added sugar totally, or at least keep it less than 5% of the total calories. Coming to the other this sugar, the important thing is the glycemic index. So what is glycemic index? Whenever we consume any type of carbohydrate, it leads to increase in blood glucose level and increase in insulin level. So there are certain carbohydrate which leads to a very rapid fluctuation in insulin and glucose level. These are called food with high glycemic index. So what is the effect of high glycemic index food? There'll be a rapid fluctuation of sugar as well as insulin level. And as these high level goes down, there'll be increased hunger pangs. And again, there'll be higher levels of these. So they release the energy quickly, but they make you feel hungry sooner, and then you tend to eat more. But if you are eating a carbohydrate with low glycemic index, then they release the energy slowly and they make you feel fuller for a longer time, and then you tend to eat less. So hepatic steatosis, when compared with rapidly absorbed sugar as compared to slowly absorbed sugar, hepatic steatosis actually decreases when you consume slowly absorbed carbohydrate. And low glycemic index diets are intervention for obesity, and it has been proven in multiple systematic reviews and meta-analysis. And along with glycemic index, there's also role of glycemic load. So for example, watermelon, the glycemic index is although high, that is 72, as compared to white rice where the glycemic index is 58, but its energy density or the glycemic load of watermelon is much less. This is 6.5 as compared to white rice, which is 19.4. So if you are eating just one serving of white rice, which would be equal to 3 servings of watermelon. So when you eat white rice, your glycemic load is too much, which is 3 times of the watermelon. And so glycemic load is divided into 3 types: low glycemic load, moderate glycemic load, and high glycemic load. High glycemic load is when you're consuming more than 20. So, the food which in high glycemic load are white rice, white pasta, baked potatoes, sweetened fruit juices, and low glycemic index foods are basically vegetables and fruits. So instead of eating maida or normal atta, it's better to eat either whole wheat flour or multi-grain flour, which have got low glycemic index. And similarly, instead of eating white rice, it is much better to eat brown rice, which is better. Or if you can eat black rice or red rice, which is even better, because they have low glycemic index and they have much higher fiber content. Coming to the fat content of the diet. So what are the factors which we should look when we are choosing a cooking oil? We should look at these. What is the saturated fat content, trans fat content, unsaturated fat, that is MUFAs and PUFAs content, what is the omega-6 and omega-3 ratio, cholesterol content, smoking point, and refined oil. So without going into much detail, the saturated fat content should be less than 10% in the whatever cooking oil we choose. Trans fat should be 0. So we should look at the label and we should see that trans fat is 0. And both the saturated fat should be replaced by monounsaturated and polyunsaturated fatty acid. Monounsaturated are much better. And among the polyunsaturated fatty acid, the omega-6 to omega-3 ratio should be, there should be more of omega-3. And cholesterol content should be again preferably 0. And we should check the smoking point of the oil, and compared to refined oil, cold pressed oil are much better. So the best would be choosing a olive oil, extra virgin olive oil or extra light olive oil. But this being expensive, we can choose canola oil, because multiple studies have shown that this has got better content of PUFAs and MUFAs. Or even cheaper option is having a rice bran oil, which is in combination with safflower oil, which is there in Saffola Gold. And also we should avoid trans fat, avoid saturated fat, and we should eat much of unsaturated fat, which is much there in fish, avocados, nuts, and also in olive oil. And does the cooking fat type alter the type of glycemic response? There's been interesting study where they use 3 types of rice and 3 types of fat, that is ghee, coconut oil, virgin coconut oil, rice bran oil, and whether they added oil before cooking or after cooking or during cooking. And it was found that the red rice was the better, and when it was cooked with the rice bran oil, and when the cooking oil was added during the cooking. So this was an interesting study, so I mentioned this. What should be the protein content of the diet? Although the data are limited for obesity, actually high protein diets cause weight loss because of multiple mechanisms, like increasing satiety, improving glucose homeostasis, increase meal-induced thermogenesis, protecting lean body mass, increasing energy expenditure. And the recommended protein intake should be about 20% of calories, or at least 1.5 grams per kg of the body weight. And the best source is either soy protein or also dairy protein, which is low fat, and fish and poultry. So in our patient, what he was originally consuming, it was 2,843 calories. I advised him to cut down with his calories to about 2,000. And also the carbohydrate content, which was way too high, which was about 16 to 1700 calories, we reduced it to about 1000 calorie, that is 50% of the 2000 calorie. Fat content remain also we decreased, and we increased the protein content of his diet. So this was the dietary prescription. With this, over a period of 3 months, he did improve. So dietary recommendation for person with obesity or for person with NASH, he should consume hypocaloric diet to achieve 7 to 10% of weight loss. And so he should reduce the calorie intake by 500 to 1000 calorie. He should consume low carbohydrate diet. The carbohydrate content should be 50%, and less than 5% should come from added sugar. We should check the labels of all the food which we buy, how much is the added sugar. The fat should be about 30%, and protein should be 20% of the calorie, which is 1.5 grams. He should avoid diet containing high fructose containing drinks. He should saturated fatty acid with PUFAs and MUFAs. Prefer oil with more health benefits, and increase soy content, increase fiber content. And ensure adherence to whatever diet he chooses. We should ensure adherence. So only 2 take-home points which I would like to emphasize. One is to decrease the caloric intake, that is eat less, and the second is eat less of carbohydrates. if the person or the patient carry home only these 2 points and ensures adherence only to these 2 points, that is, should reduce the calorie content and should reduce the carbohydrate content, then he would much benefit, and he would improve in his obesity as well as cardiovascular and hepatic fat content. Thank you for your patient hearing.
Thank you, Ashish. As usual, your content and the uh, whole thinking process to achieve the goal of diet and which type of diet, which type of fat, which type of carbohydrates have been very, very educative and very useful for all of us. Thank you very much, and we'll take up the questions later on. It is not only the diet which makes a difference. So if you only do the dieting, probably you might not achieve the desired goal of weight reduction. Probably exercise is equally important, added to the diet schedules, which is going to give a better result. To understand what is the pathophysiology of exercise and how the exercise is changing the pattern of obesity, we have none other than Dr. ANIL ARORA, who is the mastermind behind these webinars on obesity, and which have culminated into better understanding of this disease, this pandemic of obesity. So I'll request Dr. ANIL ARORA to take up this particular aspect, pathophysiology of exercise, a very difficult subject. Probably he's going to make it simpler for us. Thank you. Anil.
Thank you, Professor Rai. Are my slides visible? Can you see my slides?
Yes, we can see now.
Okay. Thank you for the elaborate introduction. The topic which has been allotted to me is pathophysiology of exercise. Obesity, by definition, is any accumulation of the fat in the body which endangers your health. This is the definition which has been proposed by one of our senior colleagues from All India Institute of Medical Sciences, Professor Anup Mishra. And this is the Asian definition of obesity. Anybody who has a BMI of more than 25 is overweight, and any BMI of more than 30 is obese. BMI is typically calculated by dividing the weight in kg by height in square meter. So all of you should go back, measure your weight and height, and look at the fact whether you are normal weight, overweight, or obese. In case you are overweight and obese, please follow what I'm going to tell you in terms of the physical activity. Why is it that on Christmas Eve, we are trying to discuss this issue of boring issue of obesity and overweight? The incidence and the prevalence of the obesity has tripled since 1975. This is the data from India, which shows that 39% of the adult aged 18 and above were found to be obese and overweight. And if you look at the recent publication, 38 million children in India under the age of 5 were overweight or obese in 2019. So a problem of yesteryears, that is underweight, has suddenly blossomed into something new called obesity. Why is it that we are becoming more and obese? I think Ashish has very clearly told us that most of us, especially in the North India, have a tendency to have much more intake than what we need to have. We have sedentary lifestyle. That means we are so used to using the remote controls of the TV and other channels. We are used to be living in a condition like this with a sedentary lifestyle, coupled with underlying genetic factors and in presence of the social and cultural factors, with the need of drugs which themselves cause obesity, and with 30% of our own population in India having some sort of psychological stress, is what culminates in the obesity or overweight which we tend to discuss. And this is an excellent publication which is from US, which has analyzed the data over the last 5 decades in the world, especially in the US. If you look at the last 50 years, starting from 1960 to 2010, you have more and more white collar jobs. People are more interested in customer care job, work from home, and the Uber related job. If you look at the jobs which require manufacturing, they are coming less and less in number with passage of time. Agriculture jobs are getting less and less in number of time. In addition, there is a concomitant decrease in the energy expenditure. The more sedentary work you have, the lesser will be the energy expenditure. That means you tend to have less expenses of your energy with passage of time. What has that resulted in? This is an excellent analysis over the last 50 years, again published with the same group, which have shown that over the last 40 years, average man has gained around 50 kg of the weight, whereas over the last 50 years, similarly, if women tend to be 10 kg fatter and heavier than they used to be about 50 years ago. What has been the cause of unmasking of this obesity? In fact, about 10,000 years ago, there was an agriculture revolution. Then came in the concept of supermarkets, which started in the Western world and then percolated in India. And then you have the concept of so-called e-marketing. That means you do not even have to move out of your bed. Just dial a pizza, dial a Swiggy or a Zomato, you will have food at home. So you have easy availability of the food at home, and you have already a genotype of fat which is making you adaptable to survival. So in presence of thrifty genes, if you tend to have easy availability of food, that is what leads to obesity. And sedentary lifestyle is an important determinant of the obesity. So ultimately what happens in a person who has been obese, what do we do to them? So it is a balance between the energy intake, that means you restrict your diet, and it's been very eloquently presented by Dr. Ashish. And then how can you spend in terms of your energy expenditure? That is the physical activity. So obesity is the imbalance between the two. So net energy balance, if it is more than you become, if your intake is more than you become obese, if your expenditure is more than you tend to lose weight. So what is an energy expenditure? Suppose a person loses 100 calories per day. If you look at the breakup, 50% is lost because of the basal metabolic rate, which you cannot change. In 10% of the energy is lost when you try to digest food, whatever you are taking. But look at this component, which is manageable, which is modifiable, which is correctable, and which can be subjected to changes. This is called non-exercise activity thermogenesis and exercise activity thermogenesis. Let me tell you, what does this mean? 50% of the energy is just maintained when ATP is consumed in the physiological process of, say, sodium potassium pump, and simply trying to maintain the homeostasis of the body by maintaining the resting potential of the cell. But look at this 30% of the energy which we use, which is in normal day-to-day activity like walking, sitting, standing, or doing a household work. That is 30%. And you spend only 5% of your energy if you do a planned exercise activity, whereas 10% of the energy is spent when you eat your food in an effort to digest it, assimilate it, and metabolize it. So what is physical activity? Physical activity is a loose term which is often interchangeably used with exercise. But let me make a clear distinction between the two. In fact, correctly defined, physical activity is all movement that creates energy expenditure, whereas exercise is planned structure activity. Physical activity is the most variable component of the total energy expenditure, which suggests that we should target something which is within our hand. Genetic is not in our hand, but exercise is in our hand. So when you talk of physical activity, the first component is non-energy, non-exercise activity thermogenesis. What does this mean is that if you are simply cleaning your house, taking your children out, strolling in a park, cleaning your verandas, trying to take your dog out, shoveling your eyes, or even cleaning your floor, every single thing leads to expenditure of energy as compared to the sedentary lifestyle. So look at this total energy expenditure. As much as 30% is used for non-exercise activity thermogenesis, which most of us tend to ignore. And look at what happens. Simply doing the basic job of tidying the house, gardening, mopping the floors, doing the dishes, removing the ice. This is not a problem, especially in Delhi. But if you look at places like Srinagar or Western world like Canada, US, this is an important issue. Then simple child care. You lose so many calories per day by simply doing these simple activities, which most of us tend to ignore. So indulging more and more in day-to-day activities rather than being sedentary, lying down or sitting at home can induce weight loss by increasing your non-exercise energy expenditure. What is exercise? Exercise is basically a physical activity that is planned, that is structured, and that is repetitive for the purpose of conditioning any part of the body. Exercise is used to improve your health and maintain your fitness, and it is an important part of your physical rehabilitation. Now, let me give you the physiology of the exercise. How does the muscle contract? Now, if you look at the human body, it is made up of a muscular body is made up of number of muscle bundles, and these muscles are made up of muscle bundles. Each muscle bundle has a number of fascicles, and all these muscle fibers have number of components or myofibrils. These myofibrils are made up of these proteins called myosin or actin. The whole muscle is made up of hundreds and thousands of this important component called actin and myosin. So when you start exercising, this sarcomere or the basic component of the muscle unit which hosts this, it starts having a cross bridge between the actin and myosin. So it is a seesaw movement. It is a pivoting movement because of the release of the calcium from the action potential generated by the exercise. So this is what happens. Once there is a action potential which is generated by the exercise, calcium comes into the lumen of the muscle, into the cytoplasm of the muscle. It attaches to this component called troponin. Attachment of the calcium to the troponin takes away the actin from the myosin, and then myosin is able to get attached to the actin. This movement of the myosin to the actin needs the utility of ATP. So when myosin is attaching to the ATP, there is a release of the energy. This release of the energy produces so-called power pump, which leads to the movement of the muscle. So as this myosin head has ATP, it breaks up into ADP, and then the energy which is generated is able to push the actin filament onto the myosin. Subsequently, more ATP comes and then tends to detach this myosin head from the actin. So with this repeated attachment and detachment of the myosin head onto the actin filament, you have extensive use of the ATP. This is what Ashish was going to tell us. If you spend your ATP, so whatever you consume, you may be able to get rid of it. So at the end of the contraction, you need to have ATP. So in the process of muscle contraction, you need both ATP for muscle relaxation as well as for the contraction. So what does this ATP do? When you start exercising, initially the muscle has store of ATP which lasts only for 3 seconds. If you continue to exercise after that, there is a system called phosphogen which will generate ATP for you, which is needed for muscle contraction. But then if that is also depleted, the muscle uses glycogen which is stored in the muscle itself for producing ATP. But glycogen conversion to lactic acid, which produces lactic acidosis, which produces fatigue. Hence, after some time, you need to have breakdown of the glucose to give you enough energy to continue with the process. So let me show you, once you start exercising, what happens. In the initial phase, your muscle ATP lets you exercise, and as that is depleted, you have a creatinine phosphate, which will be able to take you for another 40 seconds. Subsequently, you will have a muscle glycogen, which will let you run for another few minutes till you need persistent source of glucose and persistent source of fatty acids. So what exercise is doing is depleting your stores of glucose as well as fatty acids. So the major purpose of doing exercise is to use ATP by consuming lot of fatty acids and glycogen from your fatty tissues which are already available. So in fact, there is also evidence at cellular levels that once you start exercising, you tend to have more beta oxidation of fatty acid. That means you burn your fat. You tend to decrease the collection and the deposition of the fat in the liver. You tend to improve your insulin sensitivity, thereby reducing the injury to the liver. In addition, the moment you start exercising, you should know what is the degree of exercise you are doing. One way of measuring exercise is by very important factor called metabolic equivalent. What is a metabolic equivalent? This is the amount of the oxygen which is consumed while sitting at rest. That means if a person who is sitting at rest consumes around 3.5 ml of the oxygen per kg of the body weight per minute, he'll be able to lose around 70 calories per hour. That is the basic expenditure of the energy in simply sitting and breathing. This is one metabolic equivalent. Just because you happen to be a human being, you are breathing, your heart is pumping, your metabolic function is on, your brain is working, you are spending 70 calories per hour. So what do we do if we need to increase our activity? If we want to increase our activity, our body should have a potential to use more oxygen. If you use more oxygen, you'll be able to burn more ATPs, you'll be able to do more exercise. How do we do that? By consuming more oxygen. It is based on a simple formula in which you multiply 15 by heart rate, which can be achieved maximally, and heart rate at rest. Now 15 is a constant, heart rate maximum is a constant. So what you are left with is a basal heart rate. So if your basal heart rate is low, look at the classical example of Boris Becker, who in fact won the Wimbledon championship at his debut at a young age of 17. His baseline pulse was only 38. So if you have a baseline pulse of 38, you will have a far more potential to increase your heart rate to a maximum without getting fatigued. That means you can use a lot of oxygen. So one variable which you can do to exercise is to decrease your basal heart rate by being medically fit. So who is a person who is medically fit? A person who is medically fit has more developed cardiovascular system, has more profuse capillaries of the heart as well as the muscle, is more likely to have larger size of the muscle fiber, more mitochondria, and all those organs and the enzymes which are important for the muscle contraction and the activity. So how do we categorize exercise? The very fact that you can simply keep lying down in your room on a table, just looking at your laptop, changing the channels with your remote control. So you are just losing about 1 to 3 METs per day. That is 70 kilocalories per kg per hour. Whereas if you're doing light exercise, like you still are not uncomfortable in your breathing, you can spend up to 3 METs per day. But if you do an exercise which can have a noticeable change in breathing, but you can still keep conversing, then you tend to lose about 6 METs, that is metabolic equivalent of energy. And if you're doing vigorous exercise, that means you are using 60% of your maximum oxygen utilization capacity. That is the time when you will have a noticeable breath, and you are using 9 METs. 9 METs will be equivalent to about 9 into 70, about 630 kilocalories per hour. So what does exercise do? Exercise does give you 2 types of benefit. It is useful, as Ashish told us, in control of diabetes, hypertension, non-alcoholic fatty liver disease by reducing weight, but it also has a potential weight independent effects. What are the weight independent effects of the exercise? That it gives you confidence, it gives you dignity, it tries to reduce the deposition of the fat in the liver, it tries to decrease your depression and anxiety, and as Dr. Setu Babu told us, with increasing anxiety and depression, you tend to eat more. It improves your cardiovascular fitness. It improves your insulin sensitivity. It tends to control the blood pressure. So you have a lot of advantages of exercise other than losing weight. So what are the recommendations? Recommendations are that if you are using only 30 minutes per day of exercise, you are losing 1000 calories per week. So that way you will never be able to lose weight. If you want to lose at least 2 to 3 kg of weight, you need to exercise for at least 45 minutes a day for 5 days a week, and you'll be losing around 1500 calories. If you want to lose 5 to 7 kg of weight, you need to exercise at least for 60 minutes per day on daily basis, not on 5 days a week, if you want to lose about 2000 calories. And it is also important to maintain your weight loss after dietary restriction if you have to exercise for a period of about 60 minutes per day. So best results are achieved in presence of calories restriction, as Dr. Ashish very rightly said. So even if you're exercising, mind you, you have to remember the caveat is you cannot keep on just hopping up for the food or just snacking intermittently. We have heard of something called pedometers. Let me give you the basic principles of what it does. A typical 70 kg person of average height, say 1.73 meter, who is walking and running at 3 miles per hour, that is the average walking speed, will burn around 40 kilocalories per 1000 steps. In one step, you lose 0.04 calories. In 1 minute, you burn 4 calories. So that is the basic equation by which you can measure the number of the steps. So if you want to lose 1000 calories, you have to exercise or walk for at least 10,000 steps daily. Exercise alone cannot be important for control of the weight, because what you need, if you look at the data presented recently, exercise alone will make you lose this only this much percent of the weight. Diet will be making you lose more weight, but if you combine both exercise and diet, your weight loss will go up. To summarize, ladies and gentlemen, sedentary lifestyle is an important contributor for weight gain. It should be treated as a potential target area in weight reduction regimen. So a constant effort of increasing your non-energy, non-exercise activity thermogenesis is extremely important. One of the variables you can control is your resting heart rate to increase your maximum utilization of the oxygen during exercise. So if you do exercise regularly, you will have hypertrophy of the heart, you will have less blood pressure, you will be able to tolerate exercise. Classical example, I have already given you Boris Becker. So if your baseline pulse is low, then you'll be able to tolerate the exercise better. Non-energy exercise activity also and exercise also gives you weight independence, like improving your brain functions, hypertension, diabetes, your overall confidence in the total scenario of the weight loss. Physiology of the exercise primarily uses ATP, which is the molecular currency of the muscular contraction. It also, because it keeps using glucose, glycogen from the phosphorylation and oxidation of the fatty acid in the body. Exercise alone as a primary treatment for management of weight loss is insufficient.
अनिल का अब तो नोना और वो भी करते हैं हाँ दोनों आते हैं हाँ नोना नोनी वेपर
non
ये ऐड हो गया कब से ऐड हुआ है कजन्स में अनिल
moderated.
अच्छा हाँ पहले तो नहीं था अब तो रोज ही अनिल के आ रहे हैं जोक्स भी आ रहे हैं उसमें और ये वेबिनार के
I think Dr. Bansal's mic needs to be muted.
I'll stop sharing my slides and go back.
Dr. Naresh, please mute your. Kindly mute.
Devlina, can you mute Dr. Bansal's mic?
Thank you, Dr. Arora, for a wonderful talk. It was a beautiful pictorial depiction of the various electrophysiological the exercise. And you also set the ball rolling for the intensity of exercise and the timing. And to address beyond this, we have none other than General Anil, who will be speaking to us on the timing, the intensity, and the duration of exercise. He is currently a senior consultant gastroenterologist at Kalinga Institute of Medical Sciences. He has served for more than 4 decades in the armed forces, and his major contributions in the field of gastroenterology has been phenomenal. He has authored several books, and he's a wonderful speaker. Over to you, General Anand.
So can you see my slides?
Yes, we can see.
Yes, sir.
And you can hear my voice?
Yes,
We can hear you, sir.
Okay. Dr. Anil Arora has been very kind. He has almost covered everything. And I'll just give a different perspective to the same thing. Can I request Dr. Naresh Bansal's slides, the sound to be muted? Okay. So this is the outline of my talk. Basically, there are 2 parts of this talk. One is who should exercise. That means what should be our aim in exercising. That means should everybody exercise or only those people who are overweight, they should exercise? And that is the question I'll be touching here. And second is the practical aspects, how we should exercise and how much we should be exercise. And how do we deal with the human mind which doesn't want to exercise? And that is what we are going to discuss. And to begin with, I'd like to introduce you to an introduction. This lovely bird, it is called ruby-throated hummingbird. It has a proper name also. But it's important to realize that it's a bird which lives in South America and every spring it migrates to North America for breeding. The few things about this bird: it weighs about 3.1 gram and the size is equal to your thumb. And before the migration, it gains about 2 grams of weight. Before the flight, that is 64% increase in weight. That means it becomes morbidly obese and also develops non-alcoholic fatty liver disease. And during the spring migration, it has a non-stop 500 miles flight, which loses all the weight in a single flight. Now, the intention is to say that one can lose weight by exercising, but it is also important for you to realize that it is a bird and its metabolism is different, and the same thing will not happen to human beings. If the human beings ran for 500 miles, they will probably not lose weight, they will collapse in between somewhere. So most obese people and over half the NAFLD people are inactive, and almost half to third of them have virtually no physical exercise. And as Dr. Anil Arora has said, intake is more than required and expenditure by exercise is less than optimum. Lack of activity causes other problems too. There is physical deconditioning. Liver fat content by MR spectroscopy correlates negatively with V2 max and dependent on age, gender, and visceral adiposities as well. In addition, there is an entity known as sarcopenic obesity, and in these days, lack of exercise is the main cause of sarcopenic obesity. We now have double income and single child syndrome with indulgent parents, working moms who will order in fast food whenever they don't have time. There are no playgrounds in the schools, and there is overemphasis on the burdensome curricula, and the result is that 30% of urban children in India have become obese. If we really go into the molecular pathogenesis in the body of obesity, it will not serve much purpose, because it will be almost like searching for a wallet in the street, because the light is there even though you have lost the wallet in the home. Simple arithmetic should be remembered, as Dr. Arora has said. We are putting more food into body and we are not spending enough. So let's see who should exercise. There is a general myth that people who are underweight and normal weight, they need not exercise much, but people who are overweight, they should exercise. And people who are obese should exercise more, and people who are morbidly obese should exercise much more. It actually doesn't work that way. Exercising as a hobby leads to obesity is being very rare. Exercise is needed actually to enjoy life. Everybody remembers this Kabir's Doha, Dukh mein simran sab kare, sukh mein kare na koe, jo sukh mein simran kare to dukh kahe ko hoye. That same thing goes with exercise and obesity as well. This is the overview of obesity and exercise, and you will see that diet and exercise here can lead to about 10% weight loss in a year. If the person is obese, you require to do something else as well. If the person is morbidly obese, you also require to do something much more. And it's about 10% weight loss that leads to improvement in non-alcoholic fatty liver disease and possibly blood pressure. But many other metabolic abnormalities need much larger amount of weight to be lost. NASH is a different disease altogether than obesity, because it is a disease of people who are an average upwardly mobile Indians with visible prosperity, even if they are thin outside but they are fat inside. And RCTs have shown that exercise and weight reduction would significantly reduce NASH scores in histologically proven NAFLD. The data on non-alcoholic fatty liver disease is extensive. There are several meta-analyses, a number of studies, and I'm not going to bore you with these studies, and I'll just tell you that exercise is an effective way of reducing non-alcoholic fatty liver disease, and it will lead to overall weight loss is not even observed. The exercise will be effective in reducing the fat in the liver. And more vigorous is the exercise, more is the benefit to the patients. Now, who should exercise? This can be answered by saying that every normal person, including the underweight people, should exercise. Yes, overweight people should also exercise. Obese people with complications and those with sarcopenic obesity and NAFLD need to exercise, but there are separate problems with obese and morbidly obese people which limit their ability to exercise, and we'll talk about it a little later. So everyone should exercise. Now question is how much and how we should exercise. Let us look at that. Recently, the person in news was this Mr. Ganesh Acharya, who is a Bollywood choreographer, and he says he has lost 98 kilograms of weight. And he gave a statement somewhere that I worked out 6 hours a day. The answer is, it is not true. Sustainable weight loss by exercise is very limited. As I told you in the previous graph, it will occur in about 10% of 10% on an average. Exercise primarily to get muscles. Exercise is done primarily to get muscles to do the fat burning. Now, international guidelines mention that comprehensive lifestyle intervention would include prescription of moderately reduced calorie diet. That means there should be a calorie deficit of 500 to 750 kilocalories per day, and Dr. Ashish has given a very clear idea as to what all components in the diet should go down. Mainly those components, carbohydrates, refined carbohydrates, which have high glycemic index and high glycemic loads. A program of increased activity should be introduced as a lifestyle measure, not as an intervention for a short time. One should start with aerobic physical activity, that is brisk walking, over 150 minutes per week, equal to about 30 minutes on most of the days of week. And later, higher levels of physical activity should be achieved about 300 minutes per week and are recommended to maintain weight loss and to minimize the weight gain again in the long term after 1 year has passed. There is need for use of behavioral strategies to facilitate adherence to diet and activity recommendation, and I'll also touch upon these a little bit. Which type of exercise we should do? Aerobic or resistive exercises? Both are equally effective for reducing non-alcoholic fatty liver disease. But for reducing weight, aerobic exercises are more beneficial. For resistance exercises would lead to buildup of muscles and maybe some degree of weight gain, especially in the underweight people. So, how do we plan exercise prescription for a person? We do a pre-exercise screening. We interview in relation to the motivation, that is, what are the barriers to exercise, what is the fatigue level, deconditioning, cognitive impairment, lack of self-efficacy, giddiness and unsteadiness. Then we plan an overall exercise regime. Supervise, it should be home-based. In most cases, many people will prefer home-based only, and it should be affordable. There is no point in advising a very expensive gym and a instructor and a trainer for every person, and it should be affordable for everyone. And lastly, the exercise prescription should have a balance aerobic and anaerobic. Generally, for weight loss, 80% should be aerobic exercise and 20% should be resistive exercise. Now, pre-exercise training, we have to look at the cardiopulmonary concerns, and we ask for symptoms, signs, past and current disabilities and risk of coronary artery disease. We look at the overall physiological competence, that is frailty, risk of fall, specific musculoskeletal limitations, because many patients will say, I have osteoarthritis in the knees and I cannot run. Associated comorbidities, if there is a cirrhosis, encephalopathy, ascites, thrombocytopenia. Is the patient on anti-diabetic, antihypertensive or diuretics, which will change the type of exercise that will be required by the patient. Then in pre-exercise counseling, we look at the motivational level and how to increase it. Exercise readiness of the person, whether he'll be able to sustain the exercise on his own or not. What is the importance of change for the subject, because he's going to change his lifestyle drastically. How can I build his confidence in achieving a lifestyle change, and identify possible barriers and discuss how to overcome them. And this is how a usual prescription will be looking like. Most of it will be aerobic exercise, 20% would be resistive exercise, and some degree of flexibility and balance exercises are given. Generally, one starts with -1 level, that is, whatever is the patient's capability of exercising, we start slightly below that. And every week you start increasing the level of exercise, reach the zero level in about 1 to 2 weeks, and that is about 30 minutes of exercise 5 times a week. And then high level of exercise should be reached within a month or two, where 60 minutes of exercise almost 7 times a week he should be trying. The general guideline is he should sweat for about 30 to 45 minutes a day due to exercise, and more, in other words, what Dr. Arora has said, he should be breathless. He should not be able to talk with the level of exercise that he is doing. Whatever exercise he chooses, we should give it to him. So most of the exercise levels are tailored to the patient's need, patient's convenience, patient's liking, or limitations. In other words, if the patient wants to play badminton, that should be good exercise for him. If he wants to play tennis, that should be good exercise for him. We should not force him to start walking or running, or we should not ask him to start lifting weights, because any kind of exercise will do the job. And start from simple and mild to exercises, go up to the more vigorous exercises. Now the problem is that exercise is very effective but not very popular. And this is a very well-known diagram which has shown that exercise weight loss 3 to 5% can be achieved by 30% people in 1 year. 5 to 7% weight loss can be achieved by about 20% people in 1 year. But weight loss of 10% or more can be achieved only by less than 10% people in 1 year time. And what is it that makes it so difficult to do? So dietary changes and physical activity is difficult to perform and sustain because patients are stubborn about their own lifestyles. And therefore, there is a need for behavioral change, which is one thing we should stress on. Exercise is needed not as an intervention but as a lifestyle choice which the patient can sustain for rest of his life. And that is what is very important for causing a behavioral change. And if we ask the patient why you can't exercise, this is the top 100 answers that people have given. Most of the people say we have no time. Some people say that we are always tired. Some people say it is in my genes. Some people say it is freezing cold outside. Some people say it is raining. Some people say, why can't you just prescribe a pill for me? So basic thing is, problems are many, and therefore the solutions cannot only be a medical prescription. It has to be social, economic, educational, and genetic counseling if it is required. Behavioral modification is done on the basis of interviews. Usually a patient spends 1 minute, a 15-minute interview 4 times a year. That means in 1 year, there are about 5.5 lakh minutes which are there. And minutes which is spending with the counselor are only 60 minutes. That means only 0.0001% of time he is spending with the counselor. Rest of the time he is spending with his family members, with his friends, with the people who are forcing him to drink and eat. And that is where the efficacy of behavioral modification becomes weak. And therefore, more frequent interviews means better is the patient's adherence to exercise. And then first, you start with asking open questions as to what you already know, discuss the pros and cons of exercise, instill confidence, and give him some very measurable goal. For example, to begin with, a goal of losing about 1 kg in a month is quite good. And emphasize on raising the importance and confidence, and emphasize on turning intentions into actual practice. Then you provide information to him and give him positive feedback. You praise him if he has lost 1 kg of weight, and review his progress, revise his goals, and discuss ways to prevent the relapse, and emphasize on maintaining the actual behavioral change for the rest of his life. There are methods of self-motivation. Now there are wearables or smart wristwatches available which will keep reminding you to get up and move when you're sitting in your office, or will keep on giving you that you've only achieved 30% of your target today. And these things, there is one colleague of mine who said that he has lost 30% of his weight just by using his smartwatch. Then there are some societal perspectives as well, and this is especially true in Australia, where they changed the type of TV ads that were being shown, and restricted the number of hours for every child the TV can be watched. And that led to almost 20% drop in weight of the whole population. So if you don't show ads of the eating material, don't show the ads of fast food, and show them the ads of exercising material or how the people are becoming fit and fit, their habits also gradually change. In addition to that, Lancet had given a long article on what the government should do. The basic thing that I like to say here is that in Poland, what they did was they moved out all the fast food joints, McDonald's and Burger Kings, to the periphery of the town and replaced them with gyms everywhere. So all you could see between your house and school and between your house and office were gyms, and every office was provided with a gym, and that led to generally weight loss in whole of the population. So with this, I like to conclude by saying that exercise is required by everyone. Exercise with or without weight loss can cause significant health benefits. More than 5% weight loss is good, and more than 10% is even better. Weight loss more than 10% can reverse fibrosis also in NASH. Many obese people, regardless of BMI, have impaired exercise capability. Modest increase in exercise can improve skeletal muscle metabolism and reduce liver fat, and Dr. Arora has very clearly shown that. Genetic factors influence response to exercise intervention. People who are more prone to becoming obese are also more prone to lose weight on exercise. Resistance exercise can reduce liver fat and is about as effective as aerobic exercise, but may not lead to so much of weight loss as aerobic exercises will lead. Moderate intensity exercise, that is 50 to 70% of VO max, 3 hours a week with reduced calorie diet remains the key to losing weight. More is better if the individual starts enjoying it, but brisk walking appears effective and quite acceptable to most people. Doctors' efforts are important in bringing behavioral change, but a major effort is also required at socio-political level. Thank you very much for your attention.
Thank you, Dr. Anand. I would request Dr. Sudeep to summarize the talks and then initiate the discussion.
Thank you, Dr. Ashish. Wonderful session and a lot to learn from all the speakers. And obesity is something which intrigues me and interests me. So, for me, this was a very important topic. The bottom line, after listening to all the speakers and, practicing myself is that you have to eat less and work more. It's like your body is like a bank. You have to put less inside and spend more. Your bank account should be as empty as possible. And as rightly said, to form any good habit is very difficult. So exercising regularly and eating less is a good habit, which is very difficult to get into. Then another thing which I have realized is I tell my patients that you should not have more food at home. Your fridge should be empty. Your drawers should be empty. There should be no biscuits, no snacks, because we are very lazy to go out and buy. We'll try and buy more things at one point in time or order at home. So if there is nothing at home, you'll not end up eating more. And as Sir said, Dr. Anand, in one side, there are 100 excuses. But I tell my patients who complain of knee pain, we can't walk, spinal pain, you can just work out 1 hour sitting in your chair and lose 6 kgs in a month. It's no big deal. I've done it, so anyone can do it. So we have to, give a positive feedback to our patient, keep insisting, keep impressing. And I even, go to the extent and tell them, you will have a life which you never thought you could have if you lose this much weight. And patients who do it really come back after 6-8 months and say, we never realized we could be like this. So, this is my take of the discussion. And yes, obesity is the biggest disease around, and it's more serious and more sinister than the present epidemic that we are facing, needless to say. So let's move on to the discussion, and we can start with any questions if there are for our speakers.
Setu Babu, we have many
Yes.
of these IT people, who have a night shift
Correct.
and then they have a day shift. So how do you think the circadian rhythm or the biological clock can be set for these patients? What would you advise me for such patients?
I actually, when I was looking at studies, there isn't any suggestion that those people who work in the night have one type of diet and those people who are in the morning have one type of diet. Probably the circadian rhythm, which is called the endogenous circuit, has to be adjusted for them. But what these people do, IT people, is they eat both morning and night. That is the biggest problem, which makes them, susceptible to raise their BMI. So I think they have to train themselves in a different way and develop a fixed circadian rhythm rather than saying that, I'm working in the night, so I'll eat. So he has his lunch, which is a big one, and a dinner with lots of snacks supplied by the system also. So ultimately, there is something like you eat more breakfast, a medium lunch, maybe a minor dinner would be a better timed follow up.
What about the exercise in these patients? What should they do? Dr. Anand? Timing for a person who has night shifts.
Ma'am, I will go back to what Ashish was saying, that the shopkeeper works from 8 in the morning to 8 in the night. So 12 hours are spent sitting down. So he has to plan his exercise within that period. That is what I said that variables do. They remind you every hour that you have to get up and walk around a little bit. So 5 minutes in an hour, if you spend walking around rather than just sitting on a chair, this can help. And most of the night shift people have freedom to move around. For example, a chowkidar is there, he can move around, he can run around also. So he can exercise. There is no restriction for him to exercise.
Can I ask a question to Dr. Anand?
Boliye, sir.
Sir, even if the person is motivated, restricts the diet, how much you think would be the hindrance because of the underlying genetics, polymorphism of the enzymes, inability of the genes to get rid of everything?
I mentioned that PNPLA3 is a gene which is prone to accumulation of fat, and it is also the gene which is very responsive to losing fat on exercise. So people who gain fat rapidly, they also lose fat also rapidly on exercise. So that is the advantage they have.
There is
Why is
also, sorry.
Why is it that in the world over, if you look at the long-term data, there is a data of about 30,000 women in US who regularly exercise at a recommended time duration of say about 60 minutes a week, very well organized and uh, supervised data. And if you look at the maintenance of the weight loss after discontinuation of the exercise is very dismal, about 5 to 10%. Is that not a demotivating factor for the people who venture to exercise?
So that is what I insisted on in one of my slides, that exercise is not an intervention to lose weight. Exercise is a change in behavior. They have to become active and they have to remain active rest of their life. That is what is important. Just by changing exercise level for about 1 year, they will lead to some degree of weight loss. But if they stop exercise, obviously they will be eating again in the same manner and they will gain weight. And therefore, it's a lifestyle change which has to be maintained. It is not just an intervention for a short term.
I'll agree with that. If other than losing weight, what exercise does, it gives you so many non-weight loss benefits, including maintaining your cardiovascular fitness, decreasing hypertension, increasing your insulin sensitivity, decreasing fat in the liver, and indirectly putting it at a much higher plateau in terms of fitness than those who do not exercise. So weight loss as a primary therapy for exercise only discourages the patient because the patient do not lose weight.
That is what I said, कि सुख में सिमरन is according to that. If you are healthy and you are exercising, दुख नहीं होगा आपको.
Dr. Setu Babu.
Yeah, I think there is one more, clinical entity which has been in practice and very difficult for us to accept is metabolically healthy obesity and metabolically unhealthy obesity. You see a lot of obese people and you ask them, what do you have complaint? He probably says, no, I'm all right. There are many people who says. But then you have a lot of these people who are not detected who are hyperlipidemic. I think we need to look at those people who are metabolically healthy obesity, who can become metabolically unhealthy obesity over a natural progression. There probably the word intervention definitely comes in. I don't know what Anand says.
Sir, what I say is that metabolically healthy obesity is a misnomer. Anyone
Okay.
who is healthy today and overweight and he goes on towards obesity, he will not remain healthy for a long time. It is a matter of time that insulin resistance will come. It is a matter of time obstructive sleep apnea will come. It's a matter of time hypertension and diabetes will come. All these things will follow. If it has not happened so far, it will happen tomorrow.
No, that is a
I will agree
patient
with
who
you
requires
because you
intervention.
already have a one hit and you are just waiting for the second hit to start the cascade of events.
The primary hit is there.
Yeah, can we, Dr. Rai, Dr. Jayanti, Dr. Sudeep, can we take the question to the audience also?
Absolutely, sir.
Chat backs.
Sudeep, you can take up the questions in the chat box.
Someone has asked, is yoga more beneficial than maybe aerobic or anaerobic exercise? Dr. Anand would
I can
probably
answer
like
that.
to answer.
I personally feel that yoga is again exercise which is done to keep the mobility of the body and to keep you healthy. Yoga is not for losing weight. If you have already gained weight and you are overweight or obese, yoga will not let you lose weight. It is not a good exercise for losing weight.
So very often we find that the weight comes down, but the truncal obesity never comes down. So for that, you recommend some specific exercises for the truncal obesity, which is a major factor for a fatty liver and other problems related to that.
I would slightly change your statement, ma'am, that weight comes down but the abdominal obesity doesn't come. I like change it to the subcutaneous fat comes down first and abdominal fat goes last. So they have to keep at it and that will also go.
A similar question I also
Dr.
wanted to
Anand.
ask Dr. Anand. So when we exercise our abs, do our visceral obesity or that can come down?
No, I don't think so. Abs are different things. The fat in front of your abs is also a different thing, and what is inside the white fat is entirely different thing.
Dr. Anand, one
Sure.
important thing which I wanted to ask you was that fit fat. This is a term which is given that if you do exercise and you are still not losing weight, but it adds to your exercise capability and view to for exercise and other things. And what is this important? Why it is important that even if you don't lose, exercise is important.
Very important, sir. Exercise makes you fit, and it will have many benefits apart from losing weight. Even if the weight is not lost, the fat in the liver still goes away.
That's the important thing.
That is important. Similarly, there are so many other metabolically benefits that will come to you. Physical mobility improves, your exercise capability improves, your ability to enjoy exercise also improves.
Dr. Roy, I showed you that slide where there is a very good cellular mechanism by which exercises does you so many good things. One of them is by increasing cyclic AMP level, it tends to bring the GLUT4 receptors onto the surface of the cell, thereby increasing the intake of the glucose into the cell. Basic problem in patient with obesity and hyperinsulinemia and metabolic syndrome is they are not able to utilize it. So not only does increasing AMPK level increase the GLUT4 receptor migration onto the surface, thereby increasing the insulin sensitivity, they also tend to inhibit lipogenesis and tend to increase beta oxidation. So by all means, it is a win-win situation. That is precisely what we are trying to say. Even if you do not lose weight, a weight loss of 2 to 3% may be totally inconspicuous. It may be totally obsolete, but it does add to your fitness. Short of that, as I said, it gives you cognitive benefit. You are more confident. You have a positive energy balance. In addition to the lot of metabolic changes which are occurring. And believe me, if you continue to do it over a period of time, you'll be the person who will realize if I do so much of exercise and if I go back and overeat, so I'm the most foolish man. I think it is just a chain of events which reflects directly.
I thought I'll ask Anand, I think what is this adipocyte resistance so that these people do not respond to whatever is the given target exercise. There are some small group where in spite of all your, modifications, these are the people who have to go for some kind of, bariatric intervention. I think that group has to be analyzed. And there is also some interesting data. If you have some markers to say, this X or Y will not respond to your dictated lifestyle or dietary modification, such people need not even go through the, all these cycles and could be put to bariatrics. I don't know what you call that.
Can I respond to that?
Yeah.
It is your
point of discussion.
Pessimistic approach, Dr. Setu Babu. We have something to offer to you.
Yeah.
Till you have something which is better in terms of biochemical or genetic marker or any genetic marker which can tell you which patient will not respond. Till then, you have to bank upon it. If you are looking forward, you see, this is a total myriad of events. When you're exercising, as I said, your self-esteem, your confidence, cognitive behavior, your ability to remain fit, and multitude of actions all cannot be one gene dependent. You need to have polymorphism of everything. So till we have a clear answer of who will not benefit, I think we should not discourage that just because you are not likely to benefit, stop exercising. That I think is a pessimistic way of looking at it.
No, I agree. Whether optimism or pessimism, but do you have some biomarkers to tell, okay, this fellow will not respond? Why give him the hardship of going through all these things? Why not you offer him a better beneficial endoscopic or, some kind of a bariatric surgical procedure? I mean, this is for a discussion, not for a.
I agree. But then, as Dr. Anand said, exercise is a part of enjoyment. It's not only to making you lose weight. It gives you so many additional benefits that cannot be taken away.
And sir, in any case, bariatric or endoscopic, obesity surgery or procedure cannot be the first line ever. You have to give a trial of weight loss for at least 6 months, if not more, before you go on to, because they are associated with their own side effects, and exercise per se and dieting is as safe as they come. And yes, it's very easy for the patient. I recently saw a patient, she was being given some pills in a tablet, and it was a magic pill. She would take 4 pills in the night, pass 15 stools in the day, and it was told to her she'll lose weight. We know, this is all wrong. Yeah. And these people are not accountable for what they are giving to the patient. And patient is taking these things hoping they lose weight.
And I'll add to what Sudeep has said. Lifestyle change has to be part of every other regime as well. Even if you're offering drugs, even if you're offering endoscopy, even if you're offering surgery, the lifestyle modification is a constant thing in all the people. And if the person is not in a hurry to lose weight, I think even if he loses 5 to 7% every year, in about 3 or 4 years, that will be okay.
Yeah, this I would add what Dr. Arora had said, that non-exercise thermogenesis, like taking up stairs instead of going up the lift, or even cleaning your house. All this also is important, and this is also part of lifestyle changes that
definitely.
Another thing is doctors tend to sit continuously on his table and does not get up to see the patient. So if everyone is doing a small thing of getting each time from his chair, going to the examination table and examine the patient, and then keep standing for some time, walking for some time, he will definitely lose weight. I think this non-exercise or day-to-day activity is going to make difference.
I think best thing for the doctor will be to go out to the reception, get the patient from there, and drop him back there.
That's right.
I would also add that
all over the world.
That sometimes if we offer the patient that if we can take up some sports, for example, like badminton or golf or anything, that is much more enjoyable than going to a gym, and that he would tend to stick more to it if the sports and the enjoyment associated with sport is associated with it.
Actually, group activities are always better than a person working alone. If there are
It has been
people
proven.
doing together, every activity can become enjoyable if they are like-minded people.
The
Yeah,
bottom
question.
line of frequent small portions of meal rather than going for ketogenic diet or Mediterranean diet. Would you like to comment on that?
Yeah, I think it is a psychosocial behavior because that snack one which I was telling, that you limit yourself to 200 calories of a snack. But sometimes we asked sometime back, this is a joke which we put. We asked one patient to take only one chapati. Then he put a huge big chapati of say around 50 centimeters and said, "Okay, I eat only one chapati." I think what Anand also said is, I think ultimately there is a balance between behavioral approach to the whole thing, and it is very difficult to do exercise and very easy to eat is the most biggest problem in all the management, whatever we talk. For example, if you interview your patients in the post-COVID, most of them said that yes, we gained weight, even a small portion. I don't know whether this, except those people who suffered from COVID, majority people seems to have weight. I don't know what is the comment of or observation by other panelists.
Weight also.
Dr.
I totally
Setu,
agree with you, sir. People at home have gained weight.
Yeah. So I think
Dr.
this is the
Setu, one
problem.
point.
Sir.
I was just asking that intermittent fasting, and what is your take finally for the people? What should they do? Should they restrict their timing of eating, or they should do fasting every alternate day and things like this? What is the best course?
Yeah, the data has shown that intermittent fasting is a very good. The other part is a good one. The other one which probably looked at is ketogenic diet. We didn't speak much about it, but then there is a lot of excitement and a lot of thing about, which is actually basically get the more energy from the fats and less of carbs, and then distributing it in more in the morning and less. And then the so-called intermittent fasting could be sometimes 2 weekend fastings or maybe once in 5 days. There isn't any regulatory or any saying, but overall, if you look at the data, it says intermittent fasting is good, and which is actually been the guidance which is given by all our seniors or our parents is go for fasting. You make some excuse to fasting. The only fasting which I know is Sivaratri. Remaining days there's no such fasting. Sivaratri, everybody ritually does the fasting, and many of them break their fasting in the evening. And again, this Ramadan seems to be a much more. I was surprised to see about 30 articles which talked, and then we never looked at. Actually, some of us could take it once again, whether a particular type of food with them, or the particular type of this, because this follows two paradoxical. What I said is a huge meal in the morning and huge meal at bedtime is not the convention, but those people somehow lose weight seems to be interesting. Or is there a group which takes a different kind of food? We never analyzed what food they take. At that time, again, it contains kharjur, which is very highest calorie yield. If there is any food, we tell our patients take kharjur. The so-called dry fruit business, more than that kharjur seems, it almost gives 500 calories. So I think this is where we need to have more understanding. I must thank Anil, which brought out a lot of some of these delicate points, which we never read so detailed. But I was amazed to see a lot of literature accumulating on this. We just tell the patient, reduce your diet. That's all. And then we tell the dietitian to make up the plan.
Can I make a comment?
Yes, sir.
Can I add something to
Anand.
it, sir?
Yeah, please, sir. Please, sir. It's
There is a randomized control trial which has shown that intermittent fasting is as good as calorie restriction. So it's not a better way of doing it. It's a way of doing your calorie restriction.
again,
And even when you are intermittent fasting, on the days when you are not fasting, you're supposed to compensate for what you have not eaten.
Yeah.
And on the days you are fasting, possibly you can take about 400 to 500 calories in that day.
It's like I call post-Sivaratri syndrome, where they tend to eat compensating the previous day's fasting. Yes.
Dr. Dilavri, you have any questions or comments?
Yeah, I can't see myself.
Yeah.
We also can't see you, sir.
Can't
So
see
we are hearing you.
But
We are
the
hearing.
host has stopped my video. Anyway,
No, but you can talk.
My comment was that body is like an oven. If you must keep the oven burning with small amount of fuel. If you put too much fuel, too much liquor, too much cola, it will start smoke. So all obese people are having a lot of smoke and they are not burning efficiently the body oven. It has to be burned efficiently by putting small amount of food whenever it requires, rather than too much of food in one go.
Well said, sir.
Sir, Dr.
I think the exercise is the burner actually. You burn it with exercise, I think. You said very good way. Yes.
We can see you, sir, now. Dr. Tyagi,
Yes.
you have any comments to make?
And also I feel people are eating not for the body, but for the soul. The soul is not satisfied. Body is satisfied, but soul is not satisfied, and they eat more to satisfy their soul. And that is the genesis of obesity. That's where your behavior pattern comes in.
Dr. Tyagi, you have any comments to make?
Dr. Tyagi is not there, I think.
I think you stopped his video. Stop my video too. I wanted to go too.
We can see you, sir. Dr. Rai, I think there are no more questions in the chat box. Dr. Rai, you can conclude the session.
It was a wonderful meeting, wonderful meeting.
Wonderful meeting. And the greatest point was that we had our teacher with us to bless us on this occasion of obesity. He is an ideal person who has maintained his body till this age, where all his students have started appearing much older than him. So it's a great occasion for all of us. Thank you all the panelists and speakers for taking so much of time, effort in making us understand about this complex matter of obesity and the diet and exercise. The take-home message should be, we should curtail 30% of our calories. We should burn the remaining calories with a sufficient amount of exercise and keep us happy and healthy, because exercise is going to motivate your brains to be happy. So be happy all the time with your good exercise. Thank you very much.
Happy New Year, sir. Happy New Year.
Happy New Year to you. Happy Christmas to all of you.
Happy Christmas and Happy New Year to everybody.
Thank you, sir.
As a parting comment, I think Ashish has already given you 2 carry-home messages. I'll also like to part with 2 important messages. First is, exercise should be taken as a part of your lifestyle and enjoyment rather than as a burden to lose weight. Whenever you try to thrust the exercise on anybody to lose weight, it only discourages him, because we have shown good scientific data that exercise alone will never make you lose weight. What is more important is dietary restriction. That is the first message. Second message which I want to convey is, on my review of the literature, something interesting was found, which others have also impressed upon it, that there is something called non-exercise activity thermogenesis. As Dr. Rai was referring to, the very fact that you keep moving around your home, doing the basic household core activities, that will make you lose 30% of the calories much more than a structured unplanned exercise, than a structured planning exercise should be enjoyment. Which is so important. With that, may I request Dr. Ashish to please convey a vote of thanks to everybody.
I would like to say vote of thanks. I would like to thank all the moderators, Dr. Jayanti, Dr. Ramesh Ruprai, and chairpersons, Dr. Sudeep Khanna, Dr. Naresh Bansal, and all the speakers, Dr. Arora, Dr. A.C. Anand, Dr. Setu Babu, for giving a wonderful talk and making this discussion lively. I would also like to thank the Micro Labs for providing this academic support to this our program. And I would like to invite you to our next session, which would be most likely in next month in the new year, and we'll soon let you the dates and the topics of the next webinar. With this, I would like to close the session and thank everyone.
Thank you, Ashish.
Thank you and Happy New Year.
Thank you, madam.
Happy New Year to everyone.
Namaste, madam.
Thank you.